Hi, everyone, and welcome. We're getting a little delayed, but we are really thrilled to have Dr. Simona Kwon here with us today for both the Implementation Science Seminar Series and also as part of the Chronic Disease Seminar Series for the Department of Epidemiology at Mailman School of Public Health. And Dr. Kwon is a graduate of Social Medical Sciences, so really thrilled to have her here. So she's associate professor in the departments of Population Health and Medicine at NYU School of Medicine. She's also the director and multiple PI of the NIH National Institute on Minority Health and Health Disparity funded Center of Excellence and the NYU Center for the Study of Asian American Health, and has done some amazing work on community engagement and implementation science that she's going to share with us today. So please join me in welcoming her. I will hand it over to you, Simona.
Thank you. And I really do apologize for the weird screen share. I don't know why it's not letting me share just one of my slides, one of my screens, but I hope this is still not too confusing. But I'm going to be talking about our approach that we've used to culturally adapt evidence-based interventions focused on hypertension prevention for Asian American communities and faith-based settings. So I'm going to just talk really quickly about Asian Americans in context, present the project objectives of our Reach Far Hypertension Control and Prevention project, give an overview of our framework that we've used, and we call it our Participatory Cultural Adaptation Framework for Implementation Science, and talk about the different approaches we used in actually doing the cultural adaptation outcomes and evaluation of our project. So Asian Americans are the fastest growing minority group in the US. By 2060, they will number 39 million, or almost 10% of the entire US population. Already in New York City, Asian Americans make up 14% of the population. And the composition of the Asian American population has changed significantly and has become much more diverse. In the early 20th century, it was largely made up of Chinese and Japanese populations. Today, these groups make up less than 1/3 of the population, and the largest increases we've been seeing in New York City, for example, have been in the Bangladeshi and the Himalayan Asian communities. And so the other portion of this pie chart represents all these different diverse groups. But despite the rapid population growth of Asian Americans, they still remain understudied and poorly understood. And this is due largely to structural barriers. There's a lack of or limited inclusion of Asian subgroup categories. If they are represented in studies, it's usually small sample sizes. And systematically, there's inconsistent definitions of Asian Americans. Studies and reports will often point to inclusion of Asian Americans, but the data is only representative of East Asian communities, for example, so only Chinese and Korean, and leaving out South Asians, or are often presented as Asian American, Native Hawaiian, and Pacific Islander. There's uneven distribution by geographic region, and there are significant barriers to participation in research and surveillance data due to immigration status and language access. And there's an overall systematic barriers and lack of consistent data collection at the health systems level on race and ethnicity. In the aggregate, Asian Americans do look like they're doing better than other racial ethnic subgroups. So in terms of attainment of bachelor's degree or higher, Asian Americans are at 50% compared to the other groups. But this really masks diversity within the Asian subgroups. And so if we break out and disaggregate the data, while 33% is the US population rate, we see that there are several groups that are underneath that level. And it's really a couple of groups that are pulling the aggregate data closer to 50%. This is true also when we look at income level. The US median is 55,000. All Asians are around 74,000, but there are several groups that reside that have income levels below the US median. And in terms of limited English proficiency, in New York City, there's a large range, again, in terms of limited English proficiency, but the majority of the groups are at 50% or higher LEP compared to other populations. And in New York City, the rates are even higher. 60% of Asians citywide report limited English proficiency. In New York City as well, Asian Americans are a low income group compared to other communities. And in terms of hypertension prevalence, Asian Americans, which are the yellow bar, actually have high, significantly high prevalence rates for hypertension, higher than whites and Hispanics. And then if we break out the different groups, we see higher levels for South Asians that are actually approaching the same level as the Black and African American communities. But despite these elevated hypertension risks and the low income and limited English proficient communities that represent Asian Americans, there is a lack of CVD control programs for Asian Americans. Data limitations are part of why there is a lack of these programs, but it's also a lack of attention to the social determinants of health and structural factors like language access. Programs at a minimum have not been translated into Asian languages and have not been culturally tailored. And there's a lack of political will and motivation to engage Asian American immigrant communities, which is likely reinforced by the lack of data or misrepresentation of data on hypertension disparities for Asian American communities. So our REACH project, REACH FAR, Racial and Ethnic Approaches to Community Health for Asian Americans, had two main project objectives. Our goal was to use a CBPR, or community-based participatory research approach, to implement culturally adapted evidence-based strategies to address hypertension in 4 Asian subgroups. So we focused on the Asian, Indian, Bangladeshi, Filipino, and Korean groups. Our two main objectives were to improve healthy eating options for Asian Americans and to increase programs, access to programs that are focused on hypertension prevention. And for this presentation, I'm going to be focusing on the faith-based organization interventions that we implemented. So I just wanted to show this because REACH FAR is really a multi-level project with several reinforcing strategies built in at multiple sites and multiple sectors. But our coalition of partners who co-led this initiative with us, NYU Center for the Study of Asian American Health served as the lead agency, but we worked in partnership with the DREAM Coalition, which is focused on New York City Bangladeshi populations, Kalasugan Coalition focused on the health of the Filipino community, Korean Community Services, the oldest and largest Korean serving organization, United Sikhs, which is an Asian Indian social service and advocacy organization. And we also worked in partnership with the New York City Department of Health. So this is a busy slide, and I'm sure it's even busier since you see both my screens. But this was our attempt at trying to harness into one figure our participatory approach to cultural adaptation. So the first outer bar is that we apply CBPR, community-based participatory research approaches and principles throughout the process. We focus on using evidence-based interventions and using a participatory approach to selecting those evidence-based interventions that work at the contextual outer and inner settings of our communities. We apply an integration of culture through using a transcreation approach. And this approach really integrates several other principles, like using social marketing and understanding the surface and deep cultural domains that we need to attend to in integrating culture. And we also think about integrating additional social marketing principles and the ecological validity model, and really understanding the components and how we're adapting the different components of an evidence-based strategy. So social marketing principles to help us really understand the audience segmentation, and the ecological validity model to help us track the cultural adaptations and where we're making those adaptations so that we are attuned to understanding the fidelity and the changes we're making to the evidence-based program components. And then throughout, we use an iterative process that includes monitoring and attention to sustainability using our participatory approach to ensure bidirectionality and a continued iterations attuned to the community context that we know is always changing. So I'm sure you all have seen this slide before. It's just trying to underscore the difference between surface culture and deep culture, and how what we see on the surface, which are just things like pictures and representation of different communities on brochures, for example, how different that is from really representing cultural values and beliefs, the process that goes into decision making, the process that goes into understanding and internalizing information has to happen at the deep cultural level. And similarly, we use a transcreation approach rather than straight line translation or literal translation. It's really important for us to think about maintaining the message and the meaning of the message and the impact and emotions of that message rather than doing a word by word translation. I'll share a little bit later about this too, but when we were working with the health department and in translating some of their materials, they really wanted us to focus on a straight line translation. And one of the documents that they had included the phrase, "The ball is in your court," hypertension and blood pressure control, the ball is in your court. And they were really pushing us to do a straight line translation. And we had to push back and let them know that the ball is in your court has no meaning in the Chinese community, for example. And so those are the kind of things that we need to focus on, translating the idioms and the metaphors. So this is the ecological validity model, and it's broken out into 8 domains. And these are the 8 domains that we really paid attention to as we were doing the cultural adaptation for us to keep track of where we were making these modifications and why they were important to make. And so, for example, in terms of in terms of concepts, we made sure that we were integrating the idea of maintaining one's own health is also maintaining the health of the family. And so the idea of collectivism, which we know is important for Asian communities. And also paying attention again to community settings and context to ensure that we're sustaining the program in a way that works in the community. So our faith-based initiative our faith-based organizations were really focused across these 4 religious denominations. We've worked with the Asian Indian Sikh community, and we implemented the project in 3 gurdwaras. For the Bangladeshi community, we focused on mosques, and we worked with 2 mosques and 1 senior center that was co-located in a mosque. For the Korean communities, we worked in 3 churches, 2 Presbyterian and 1 Methodist. And the Filipino communities were focused around evangelical Protestant churches. So in the faith-based organizations, we focused on providing healthy food options to the congregate meals. And all of these faith-based organizations serve congregate meals as part of their religious sessions. And so what we did is we focused on the New York City Health Department's Healthy Eating Initiative, the New York City Agency Food Standards, and ask the faith-based organizations to implement one of the following policies during their communal meals. So all of them offered water free of charge, but the other choices were offering fresh fruit choice, vegetables, whole grain options, low fat or non-fat dairy options or low sodium dressings and condiments. The second program we implemented was a Keep on Track program. And this is a program that, that was developed by the New York City Health Department. And it's delivered in faith-based settings. And it's a volunteer-led blood pressure program. To date, the New York City Health Department had implemented it in over 200 Black and African and Latinx serving faith-based organizations. But prior to our engagement, it had been implemented in no Asian American faith-based organizations. So the next couple of slides, I'm going to focus on how we did our process around the cultural adaptation. So this is just a slide showing an example of how we use the ecological validity model to track and to monitor where we were making the adaptations. It's really important to us since we were also working across 4 different Asian subgroups with 4 different religious denominations, 4 different languages, and really different cultures. And so, you know, in terms of language, the program materials were translated into 4 different languages. Our implementers were really focused on the community and faith-based organization leaders. In terms of metaphors, we really focus on these idioms, like I presented before, like the blood pressure control, it's in your court. You know, for Asian audiences, this really didn't make any sense. We made sure to reinforce campaign messages focused around Asian condiments as a source of sodium in the diet. We made sure to embed in the content cultural values to frame the goals. All of our materials were adapted to include images of Asian families instead of just individuals, to really ensure inclusion and values that are specific to the Asian communities. In terms of concepts, we tried to really pay attention to deep cultural domains. So for example, building our materials and reinforcing messages around the idea of seva in the Sikh community, which is volunteerism as part of their religion, and using the idea of langar, which is their shared communal meals that everyone is invited to, as opportunities to introduce healthier options, healthy eating options. And in terms of context, we paid attention to policy and community context and religious context. So during Ramadan, for example, in the Bangladeshi mosques, we held programs late in the afternoon after fasting and during iftar to accommodate the breaking of the fast. This is just some photos from the Keep on Track implementation at the different sites. And some examples of the materials that we actually culturally adapted. So this is materials from the health department on the left side. So, you know, we knew it was really important to focus on sharing with the community where sodium was coming from their diet. But the graphics and the information shared was really not relevant to our communities. And our partners quickly pointed out that, you know, talking about frozen cheese pizza and you know, canned vegetables may not be, would further marginalize our communities, and that passing out these types of materials would actually make them feel that this material is not for them. And so we work with our partners to include and identify the sodium ranges from commonly eaten foods in the community. So we included frozen samosas. We made sure to include seasonings and dressings like soy sauce, the different paste base that we knew our communities ate. In addition, this is a health department booklet that we thought had a lot of the relevant information that we wanted to share with our communities. The health department was very interested in us translating. But again, they wanted us to do a straight line translation. And so it was probably about a good 4 months back and forth working with with the health department to get them to understand our vision of what this booklet could look like. But when we initially showed this cover to our community partners, the first thing they noted was, yes, there's diverse representation of people on the booklet cover, but to them, this wouldn't speak to our community partners, largely because it looked like just a group of individual people exercising or being physically active. And for our communities, they would be engaged in these activities with their friends, with their spouse, with their family members. And so they wanted that represented in the booklet. So this is the new booklet cover that we came up with, where we have people exercising with their spouse. We have pictures of family and friends and people in their community, and representation of foods that were specific to the communities. And we made sure to include information focused on Asian American grocery stores, where we knew a lot of the communities were shopping, and noting that sometimes nutrition labels were not so easy to read and translate from our Asian communities. And so making sure that we highlighted that and highlighted the different foods that our community is eating. Also within the booklet, there were, in the original booklet, there were tips, healthy tips for parents. And we knew that a lot of our communities also lived in multi-generational households, and grandparents were in charge of cooking for large numbers of the meals. And so we included information for tips for grandparents and caregivers. This is the health department's healthy meal planner that we knew we had to adapt. When we showed this to our community partners, the first thing that they noted was, nobody in our community eats an orange like this. This to them seemed very weird to them. And so that was one of the first things they wanted us to address. And we went through several iterations. So this is the Korean plate planner. And so we started off with this on the left side, where we had the plate and the oranges sliced up, and then we changed it a little bit so that one of the things the community said was, the spoon and the chopsticks would not be on either side of the plate, and so we made sure to change that. And then we ultimately ended up with this, because one of the things we kept going back to is that our Korean community partner said, for this to be a real community Korean meal, we would need to include a soup, because that's always a part of a meal. And so we made sure to include that. And this is the version that we did in Urdu for the Pakistani and Urdu speaking populations. So we also did environmental checklists of the food environment at the faith-based organizations, and we adapted the nutrition environmental measures survey to do this. And so we did it in all of the churches that were, all the faith-based organizations that were included in our project. All the evangelical Protestant churches and Sikh gurdwaras reported providing some congregational level, congregation level health promotion activities. And in addition, 2 of the evangelical Protestant churches had a mission or formal policy around support of or commitment to healthy food and healthy well-being. Very few sites included signs or posters about promoting healthy eating. And so we knew that was an opportunity for us to implement something. So our multi-pronged evaluation had several components, and really we did this because we had multiple levels and multiple sectors that we were implementing strategies across. We did a sub-study of our Keep on Track program. So while it was open to all congregate members, we consented individuals to be followed up 6 months post intervention. We did a semi-structured interviews using the consolidated framework for implementation research with the implementation site leaders to better understand adaptation, implementation, and sustainability across the different sites. And we also visually mapped our geographic reach, looking at where our Asian American population clusters were and the locations of our implementation sites. This is some baseline characteristics of our congregate members. So overall, the congregate members who participated were 56, around 57 years old, largely 60% female. The majority were foreign born. And for clinical variables, we saw that the Koreans had the highest mean systolic blood pressure and Asians had the highest mean systolic blood pressure, sorry, right here. And the Bangladeshis were also more likely to report being hypertensive compared to the other groups. And overall, 42% had been told that they were hypertensive, had high blood pressure, sorry. The majority were currently taking their medication as prescribed. In our subset of Keep on Track participants, we found that overall, from baseline to follow-up, we saw improvements on health-related self-efficacy, as well as our systolic and diastolic blood pressure measurements. And in terms of additional variables, we looked at individuals who self-reported no hypertension and individuals who reported self-reported hypertension. And we saw in general that the program was more effective for those participants who had reported hypertension, and that participants without self-reported hypertension also had significant increases in health-related self-efficacy, as well as a decrease in better improvement in their blood pressure. In terms of our CFER evaluation, some of the things we saw was the importance of understanding the outer setting and incorporating outer setting or values into the program. So in the mosque site, the implementation leader there talked about the need to create different programming for men and women and introducing the program on different days to increase participation. In the inner setting, for example, the Gurdwara informant noted that the organization's overall commitment to ensuring a healthy congregation was important in implementing the program, and that their commitment was in providing these services to their community, which included poor and uninsured members who may not have gone to a doctor in a long time. In terms of characteristics of the individuals, this was very much tied to the inner setting of the organization. So many of the individuals were church or faith-based organization leaders, and it was important to have that champion on site. And this is the representation of our reach using a mapping approach. So our goal was to understand the geographic reach of the REACH-FAR program. And so this is a spider diagram that one of our postdoctoral fellows put together for us. This includes the geocoded addresses of the 12 implementation sites, faith-based organization sites, as well as our Keep on Track program participants from the baseline survey using their addresses. And what we really saw was we overlay this with the census data on where our Asian American population clusters were. And so you can see that the sites really do overlap with our clusters. But what we also saw was that the impact, the reach of our program actually extended beyond these sites. And so really underscores that individuals and communities outside these places may have been coming to these places because of the need for culturally translated information and content for their faith-based organization, and as well as other resources. And I wanted to share this section on sustainability and scale. And so while the Reach Far program is now completed, we were able to translate the information and the programming into new settings. And so we have now engaged 6 new mosques in the Lower East Side and in Sunset Park and Kensington and Brooklyn. And so we're working with 6 mosques in these areas which serve over 5,000 members. And we've been implementing the Reach Far strategies, that keep on track. And so we've trained 35 mosques volunteers using the Reach Far materials. And these individuals conduct monthly or bi-monthly screening and counseling programs at the mosque sites. And over 600 mosque members have now received blood pressure screening and counseling at least once. And in terms of the nutrition strategies, these have also been implemented at the mosques. We've been doing this program in partnership with our community benefits plan of our hospital. So the CSP, or our community service plan, in year 1 started to sponsor fruits that were distributed during the congregate meals. And that became such an important program that the mosques themselves have now taken this up and now pay for the fruits themselves. And over 1,500 educational materials that have been culturally and linguistically tailored have been disseminated. And I wanted to also note that because of COVID, some of our programming has been greatly affected, but our trained volunteer mosque members, as well as our CSP staff, have worked together to pivot their role and activities to address what we're seeing as large need around food security in the community. And so many food drives have been now organized. There were food delivery happened. So 2 weeks of groceries were delivered to over 148 families. And we've delivered medicine to over 30 vulnerable older adult community members. And most recently, over 130 eligible community members have been navigated to appointments for COVID-19 vaccination, especially with the increase in eligibility criteria, including cardiovascular disease. So in conclusion, evidence-based strategies can improve policy systems and environmental outcomes critical to mitigating Asian American health disparities. Faith-based settings are prime locations to and can be successfully leveraged to reach large numbers of underserved Asian American immigrant communities. Using a cultural adaptation model focused, embedded with an implementation science is necessary to culturally adapt evidence-based strategies to enhance meaningfulness, reach, and relevancy. And using a systematic participatory approach adds to the gap in the knowledge base and can be used and applied to guide cultural adaptations for other immigrant and underserved communities. And this is just a photograph of our group. We adopted the program logo, Healthy Heart, Healthy Community, and these are our community partners. Thank you.
Thank you so much, Simona. That was a lot of amazing information that you fit in there despite our delayed start. So thank you so much. So I put it so that now people can unmute themselves. So I think we have some time for questions. One question I'd love to kind of start off with as people are thinking is I've been having a lot of discussions lately about whether or not cultural adaptation is a failure in the sense that we are having to start, we're having to adapt programs as opposed to starting with programs that are designed by and for the community. And you mentioned the Transcreation framework. So I'd love your thoughts on this because I think there's a lot of opinions on that. When do we adapt versus when do we start from scratch? And it sounds like you had a lot of back and forth with the Department of Health.
Yeah. To be honest, we struggle with this all the time. And we really feel, I feel very strongly that there needs to be a paradigm shift where we're creating programs for health disparity populations. If it works in a population that has lower access to resources, then the adaptation process to the general population is going to be much less onerous, much less hard to do, as you know, people feel like it's always hard to adapt for immigrant communities or racial ethnic communities. Um, I think that there just needs to be a paradigm shift in the way programs are developed, evaluated, and deemed evidence-based. So that's not really, that's not really an answer, because we do feel very strongly that evidence-based programs need to be culturally adapted to fit into the context, because the lives of, the lives and the context of these communities are very different. And so we need to be attuned to that.
Yeah, I agree. It's both, but I agree that it's almost like where we're starting from is needs that paradigm shift to begin with, so that we're not always having to just adapt.
Yeah, I'd like to make a comment. Congratulations, Simona. Great to see you. I think that giving the sad news about discrimination against Asian Americans, that the faith-based groups must be very helpful, supportive, and if you can adapt what's available locally to satisfy their cultural needs, especially with food, I think it must be helpful to deal with this very ugly side of America that seems to have grown stronger recently. And it's just very sad.
Yeah, I appreciate that, Ruby, and it's wonderful to see you.
Thank you.
The faith-based organizations in these communities really do work as community centers. This is where people go for information, not just health information, but how to navigate social services and where to get access to different resources. And so the faith-based organizations really are grappling with, the uptick in anti-Asian violence. And so and absolutely, they're getting hard hit because of COVID and are trying to, to attend to the community needs. I do want to go back to, I don't want to make it seem like the health department was unwilling to work with us. They're just, they are also working under specific guidelines, and their materials undergo lots of scrutiny and vetting. And so changing the language is just difficult to do within that context. And while it did take us many rounds of meetings to work out a process that worked, they were absolutely, they absolutely listened to the community partners. They wanted to find a way to make it work. And all of the materials that we co-created with them are up on their health department's website, and they've been, disseminating them widely across communities. And so it has been a very important relationship for us.
Hi, Dr. Kwon. My name's Ali Justo. I'm a postdoctoral fellow in the psychiatry department. This isn't really a question, but I would love to hear you talk a little bit more about the paradigm shift that you answered to Rachel's question. I agree, but I don't know what that looks like, and I would love to hear kind of how you could build the system a little bit, like what that would look like.
Yeah, I mean, it's been a little bit stressful for us doing Asian American health disparities work, because to get things funded through NIH and other governmental funding agencies, they want to see you take an evidence-based program and implement it as an R01. And there's less support to create something that is culturally adapted because it's thought of as maybe not scalable. And so we've had to think of ways to really talk about the work that we're doing and taking components and concepts that we know work and could work, and talking about how we're adapting them using CBPR approaches to really make it meaningful for our communities. And so a lot of it is, language. And so we pay attention to language a lot. But at the same time, when we get the opportunities to do it, we advocate strongly for the need for our paradigm shift, for better data collection for our communities, for better representation and inclusion of diverse populations with getting access to these programs and resources.
Thank you. That makes so much sense. And I feel like I feel like I've run into a lot what you're measuring too as your outcomes, what's relevant to the community and they're seeing as the problem at a level, but what's maybe tied to the evidence-based practice and how you talk about everything. Thank you.
I know the conversation where it's come up for us in implementation science is we're often, just like you said, Simona, we're often starting with this assumption that there is an evidence base, but who has been at the table in determining that evidence base and what counts as the evidence? And, is it just the randomized control trial and who has that been evaluated among? So it's like all those questions that we rest our implementation science studies upon and that NIH will fund are questionable.
Right. And why, it feels like now people are putting more attention. I mean, implementation science, I think, has always been, so important and such an important framework to pushing interventions forward, and stakeholders and the engagement of implementation science has always been such an important part of the work and the process. But it feels like now people are understanding how important the role of gatekeeper community organizations are, and as well as real community members as part of the stakeholder group, which I always thought was embedded within the idea of stakeholders, but it seems like it's now getting much more attention and traction, which is wonderful.
And I think a lot more attention to more of those hybrid one designs, right? Where we're understanding implementation as we're developing with those stakeholders from the start, as opposed to that bi-directional later along the line. Alejandra, were you gonna have a question? It's good to see you.
Hi, good to see you too. Yeah, so I think I have a lot of thoughts because with Dr. Shelton, we worked on actually just evaluating qualitatively the implementation of a hypertension intervention in a very different setting, Guatemala, that is being delivered for indigenous populations. So we've had similar challenges as you've had, right? Trying to adapt an evidence-based intervention that was tested in the US and in high-income countries, and now trying to translate it to Guatemala with limited resources, and then in addition trying to translate it to an indigenous population, right? With their own culture, their own habits, etc. And so I was wondering if you could speak a little bit about how what has your experience been around using some of the implementation science frameworks when conducting CBPR work, especially with marginalized communities that might not have, access to the academic knowledge, right? The knowledge that they have is different, is really valuable, but it's not academic. So I was wondering if you could speak a little bit about it.
Yeah.
And then, I think my other big type of question is, I feel that sometimes some of the frameworks are developed to work within specific settings in the US, mostly hospital-based settings, healthcare settings. And when you try to use these frameworks in community settings for marginalized communities, some of these frameworks don't really fit with the context. So I was wondering if you could speak a little bit about it. Thank you. And it was a great presentation. It was super interesting. Thank you.
I'll take the second question first. It's so hard. We did a adaptation of the diabetes prevention program, DPP, with our Korean community, Korean and Asian Indian community partners. And, you know, DPP, I forget now, but I think it's like a 16 session intervention that has now been translated to community settings like the YMCAs, but it originally was created for clinic settings to be delivered by nurses or allied health staff. And because it's a, you know, we're working with an immigrant community, we had to change the sessions. 16 sessions was just too much. Our communities couldn't give up that much time, and it spread across certain months. Invariably, we would have parts of our population going back to visit home country. When they go to home country, they visit for like a month. So then they miss all the sessions. So we had to shrink it down to 12 sessions. And some of them were longer sessions, and some of them were delivered with videos that people could look at online. And when it came down to it, CDC was like, this is not DPP, and they wouldn't reimburse for it when we try to use it as a model that health departments could reimburse for, because they thought it changed so much from DPP. So yes, we run into that. But in terms of your first question, one thing I want to make clear is the community partners that we worked with on this project, I've been working with for at least 10 years. So these are high functioning community-based organizations who we've been working with for years to build their community capacity to be engaged in research. So that is different. It does require time to build in that training component. And so so that's if you're on a 5-year timeline, sometimes these projects are a little bit less doable. The other thing is that it is possible to find high functioning gatekeeper community leaders who can really serve as that bridge to community members. And so that's where you start building those relationships and building the capacity, because if you build their capacity to do the work, they retain it and stay in the communities and are able to then kind of like train the trainer model, keep that information within the communities, and train additional community members. But yeah, it is a long-term process.
Alejandra has one last question.
Another Alejandra has a question. So it's actually in reaction to what you just said, and I'm curious if you've evaluated the skills gained by your community partners over this 5 to 10 year relationship that you have for them, and if you could speak to the way you've evaluated the values gained, the capacity gained.
Yes, we have done. So we've done kind of maybe like we've done shortcuts to social network mapping to see how the community partners have built their relationship with each other, and how they've now created coalitions among themselves, and cross share programming. And we've also actually done key informant interviews and mapped out how their own ability to be the leads on research projects and getting research grants has increased. And so, for example, Korean Community Services, when we first started working with them, they had a public health education program, and it was all focused on educating youth around public health issues. Since working with us, and that this has been like a 15-year process working with them, they have now built their program so that they do their own research, and they now have a straight line relationship with the health department, and are accessing grants directly from the health department, which they didn't have before. And the community health workers, a lot of our projects have used community health worker approaches. And so the community health workers that were trained as part of the research that we had done collectively are the ones leading the implementation on a lot of these projects. So we've seen the growth in from 0 grant funds from the health department to almost $1 million plus.
Wow, that's amazing. This is such a rich partnership, and we so appreciate you sharing all of your knowledge and this amazing work. And thank you for joining us, Simona. It was great to see you.
Oh, thank you. And I just want to note also that Dr. Ruby Sunny is one of the key people that put me on this path and like gave me the reins to be able to create these coalitions and partnerships with Asian American serving community-based organizations. So it's so fulfilling to see you on this call. Thank you, everyone.